Talk to you guys a little bit about things that concern me about using mobile health technology in harm reduction related research. And this is my singular slide. So we're gonna try and do it old school with just like a conversation. And I'm hopeful that, you know, at least some of this will be like applicable to you guys in your work, even if you're not doing mHealth related work, or if you haven't thought about how you might be utilizing these mHealth tools in your work. So I started doing mHealth related work, and I'm going to give you this sort of like trajectory because I think I've done things really poorly, and now I do them, I think, better. But and some of that is because of the training that I have received from Celia, and then also some of it is trying to be like more thoughtful about who my population is and what are the risks that they face as a byproduct of their like stigmatized existence. Um, so my first mHealth study was not mine. I worked on a project looking at toxic shock syndrome among adolescent women who were premenarchal. So the mHealth project included me texting these young women once a week on Sundays from my couch, a direct message like, have you started your period yet? If they said yes, they came in and they did a vaginal swab. And the goal of those vaginal swabs was to understand how the impact of the microbiome may have impacted their likelihood of getting toxic shock syndrome later in life. So like we could think about, I mean, Celia's face is like on the broader ethics of the project, but like focusing in on the mHealth component, me texting these young women just like, hey, how you doing? Have you started your period? You know, they and their moms had consented to this research. But like there was none data security, none. So like, I think that that's probably a pretty innocuous question, but certainly is an example of how like zero consideration was given to privacy, confidentiality, right? Like we didn't do anything to secure the data. We didn't consider what these young women might have been doing on Sundays when this text message came into them. We didn't really think about like the psychological benefits of being asked about your period and how young women may have been like waiting for this developmental milestone, or how they could have been like devastated by the onset of their period and like where it happened. So, yeah, like I think that's an example of like really cool research that was done probably very poorly. And it wasn't mine, so I feel pretty good about saying that. The next study that I did, I was at in Indiana in the Division of Adolescent Medicine, and Mary Ott is coming later this week, and I'm super excited because she was there at the same time. And should have been graduating, I decided to stay an extra year to do this predoctoral fellowship in urban health. And for that study, I was super interested in how like the situational context of particular sexual events may have been influencing women engaging in sex work risk for HIV. And I really think about how the collection of these very nuanced events, frequently in close proximity to when they've occurred, like and how that might reduce recall bias. Sorry, epidemiologists, but how it can reduce generalizations, which I think are kind of not that helpful when we're trying to understand the impact of specific events. Yeah, so in that study, we used these twice daily diaries delivered to cell phones that were locked, that we provided to the women with a data plan that they were allowed to keep after the study. And I think that those pieces of like providing that benefit to them so that specific groups were not excluded for having lack of access. It's a justice issue, right? And in that study, the diaries themselves were also locked, and it would like so people would get this survey at 7 a.m., 7 p.m., and it asked questions around tell me about your sex life. Like, have you engaged in sex? Tell me about your mood, these kinds of things. And if people hadn't engaged in sex, we asked them, like, tell me about your day. What were you doing? With this idea that we wouldn't want people to game the system, because if you said yes to sex, you got a whole lot of questions about it. And this was sort of the study that like piqued my interest in ethics, which at the time I had zero idea that that's what I was thinking about. But in this month-long study, at the end of it, we asked women about their experiences. And we conducted a little bit of quantitative analysis looking at their mental health. And what we found was that social isolation went down, depression and anxiety shifted, and self-esteem shifted. And that happened the benefit was best received among women who were the most vulnerable, had the worst scores at the baseline. And so that was the first time I started thinking about this engagement and this very high intensity data collection have benefits for people. And we asked them about it in qualitative interviews, and what we heard resoundingly was that, I mean, always we hear, right, that when your researchers and your research assistants treat people with respect and kindness, that makes people want to participate. But also being asked about their sexual behavior helped them to start to reflect on it and to think about other changes that they might like to make in their life. Further, we paid them like the sum total of $30 a week. And it's remarkable what $30 a week can do and how it might influence people's behavior, like being able to buy shampoo and other things that you couldn't get through benefits like alcohol and cigarettes. Like those kinds of things were very, very beneficial to women. And so like this idea of reflexivity as a benefit started to stand out. Then I came to Fordham, and my Fordham project was sort of a hypothetical scenario. I think you guys read, if you were given access to the paper, whether you read it or not. But it was sort of a hypothetical sort of study. I was really interested in polydrug use. I think the way that we define it is kind of amorphous. It doesn't really get at what people are doing and why they're doing it and how that impacts their risk of overdose. And so I wanted to use diaries to try and understand those kinds of behaviors, and framed it in terms of like, what are the potential risks and benefits to you through using these kinds of data collection tools. And it was the first time that I had really tried to use like empirical ethics to try and understand these things. And the thing that sticks with me the most is this continued conversation around how these methods can be beneficial to people, but the salience of legal risks and considering like what is the true value to participants and what can happen to them. It's not always about access to our data. People feel pretty comfortable reporting on their drug use. It's not that. It's that the police, for example, could somehow find out that they're in the study and how that could be utilized against them. Or the social risks of somebody finding out that you're doing this study and then maybe thinking that you're a narc. And so those are the things that I try to think about as we're moving into these other kinds of research. So for the last, now to like kind of what I'm doing, I've been doing 2 overdose-related technology studies. The first is a wearable biosensor to try and detect signs of physiological response to opioid use. So the first study was respiratory rate, activity, and heart rate, with this idea that 52% of overdoses happen in the United States when somebody uses alone. So if somebody uses alone, like there's nobody there to administer, life-saving tools like rescue breaths or naloxone. And so the goal of this research was to try and move us towards having this kind of technology available to people. And in the first study, we utilized this like very discrete product that had not been designed for opioid overdose. In that case, it could fit into the band of a woman's bra or in their shorts, right? So like perfect in terms of being discreet, really shitty data collection. Like we got nothing out of it that we wanted, because it wasn't designed for that purpose. It was designed for like athletes. So we then started to try and develop our own device, me with some engineers and medical doctors at the University of Pennsylvania, with the goal of having injectable naloxone built into this device. And at the time, we weren't thinking about sub-Q administration. We were trying to think about where on the body you could safely inject somebody and also get a good read on SpO2, like so blood oxygen saturation, and these other important biomarkers. And so we ended up creating this device prototype, which is like what this study is about. But it was, the device itself sat on the deltoid, was adhered with an adhesive that didn't always work, and the device like was the size of a deck of cards. Like there is nothing at all discreet about this device. And so everything good that we learned from the first study, which is how important the police not think, like your drug dealers and your friends not thinking that you're a narc, like the police not being able to identify you because you've got this device on, totally went out the window. And what's scary to me is that when we've looked at in the literature, there have been very few people who are working on developing these technologies who are engaging people who use drugs as a part of that design process, which I think is something that we've been trying to bring to the table, and doing a lot of formative research, which is like resoundingly what came out of those articles, like how important it is to iterate with people. And once again, you know, we heard about these perceived benefits when you're talking to people who have used opioids frequently in the, you know, in the last 30 days, like 94% of our most recent sample had experienced overdose. All of them had known people who had died of an overdose. And so the idea of the potential benefits of something that could monitor you and potentially, in our case, we're shifting to a sense and detect and alert device. The benefits are huge. The perceived benefits are huge. But the things that kind of concern me, it's like you slap a device on somebody and it's tracking them everywhere all of the time. So like how, you know, how can that data be used in a way that's not helpful to them? And in our next generation device, we're adding GPS because, you know, you alert EMS or friends, they have to know where to go to be able to resuscitate someone. And so, and our participants are incredibly disinterested in interacting with the police should they show up to the event, right? Like they're super paranoid about being arrested on some existing warrant because it happens. They're treated very, very poorly. You can't guarantee that it's gonna be EMS. And so like, that's a scary proposition to ask people to engage in this thing that could cause them harm. And thinking back to the case of the sex work study that I first did, one of the things that we uncovered in the formative research was I had asked women, would you wear a GPS tracker? Because I was super interested in where they were going to have sex and like how the physical space, like not only like were you in a bed or were you in a car, but like where was that car parked? Like how could that impact their risk of HIV? And they categorically said, absolutely not. Nope. And it's not because they didn't want to report on their sex events. We ultimately ended up collecting cross streets and then meeting with them once a week to try and get the specifics of each of these events. But they were like, this is a study about my risk for HIV. This is not a study about my life. You don't get to follow me around as I do the rest of my business. And in particular, they were worried about people who they were buying drugs from. But like, it doesn't matter who they were important about. They were very concerned about those privacy risks. And so we ended up having to pivot again, you know, showing how important these the formative research is in the work that we're doing. And so, yeah, so now we've just applied for a grant to develop like what will actually be like a real alert device. And there is an entire aim around like getting user feedback on things like what do you want like we're going to send an SMS text, and what information do you want to be contained in that SMS text? But more importantly, if we can put an alarm on this device, like what things do you want? Like, is it okay if it buzzes? Is it okay if it makes noise? Do you want the noise to be like a fire alarm, or do you want it to be something like overdose alert or respiratory depression, like, things like that? Is it okay if it flashes? So all of those things I think are critically important in developing these next gen devices. And then last but not least, a study that I'm working on uses a smartphone application to link people equipped with naloxone to victims of opioid poisoning or other respiratory suppressants, right? Because there are plenty. And so it's like Uber for overdose, wherein you see somebody, you don't feel comfortable, potentially, you don't have your naloxone on you, you hit this button and somebody who's in close proximity shows up. There's also that trigger to EMS, right? And so again, all of these like privacy concerns, and like, for me, I think about what we hear repeatedly is that peers do an exceptional job of resuscitating people. They also don't always treat their peers kindly. Like, they might steal your stuff. And so you're calling somebody who either could be treated poorly by the police or have their stuff robbed. And so there is a trade-off here in terms of like actual benefits and harms that can happen, which then raises the importance of like these justice issues around making sure that people are actually consenting to what it is they're being asked to do. So I give you guys these examples as sort of like a starting place for conversation around just, how salient these issues are, and I think how distinct they might be from like lab-based work where people are coming into a controlled environment and data collection is fairly similar across people. And you've got like a research assistant there who is hopefully doing a great job of getting informed consent, making sure that people understand procedures. With the like Unity Philly, the Uber for Overdose app, the next generation, we're gonna open that app up to 3,000 people in the city of Philadelphia. The onboarding for that is not much different than like MyFitnessPal. And so that goes beyond research into actual implementation, and then it's like 3,000 people. Like, the potential benefits to public health are huge, but also I think the risks remain. And so I guess one of the things I just would love to talk about is like, what are the things that jump out to you guys in like, because there's plenty of mHealth and harm reduction researchers in the room. And then I would also imagine there are plenty of folks who have used mobile devices to just administer surveys or to enroll people. And we don't always think about those as mHealth tools, but they are. So I'd love to hear more about like your guys' research, and if and how you're utilizing these tools, and the things that you've learned and that might concern you as you think about their application. Absolutely.
About this, the second gen device, you said it was like the size of like a card deck.
So big.
Is it something that has to be charged, like a battery?
All of it.
Like, so what's the upkeep for the participant?
Totally, it's an equity of inclusion question, right? Like, so what if somebody doesn't have a place to discreetly enter data, to safely store and charge their phone? Like, I think there's a lot to be considered there, and all of these devices have to be recharged. With this new grant, we're taking out the naloxone auto injector so we can make it much smaller and we can extend the battery life. But ultimately, like, that's a great concern, and it makes you think about like, so who's the market for this? And is it folks who are street homeless, who might have the most benefit, but also have probably more access to a responder network if they're living around other folks who use drugs? And then like, what's the value for giving it to people who are like the worried well, who were post-op and they were given like Oxycontin, you know what I mean? Right. So it's a complicated question.
So I'm getting ready to go like, 90s probably, maybe late 90s. We did this thing where it was when phone batteries were awful, where we gave like a little portable, a portable,
Solar charger?
yeah.
Solar
Well,
charger.
it
That's what I was
solar, but
thinking,
it was a
solar.
charger. You can do
Why not
solar now.
solar?
Never had it once occurred to me, like, that's a great idea.
Now you can do
Charger.
solar, but because I have a solar one.
Yeah.
Yeah, right.
Yeah, then it was just a little thing, and we bought tons of them, and so when they would come in, they could just swap out. They could charge it themselves, but if they didn't, we had a lot of various people, and so they could also come in and just do a swap. And I mean, it was old school, this idea, because we were letting them charge their phone because their phone battery would die. So this could be, now they're really small and they have solar ones.
Love it.
Yeah, and they're not expensive, so that could be a.
Right. No, I mean, these were all research studies, so people were coming in, they were getting paid, we were swapping out devices.
Carry their kings with them. So then that's the other part of like how much they got to carry, and all those things add weight to your body.
And will get stolen and lost.
But I do think the idea of giving people like a solar-based charger as part of packaging, I think is a great idea.
Other things too.
Yes.
Right.
I mean, that's the same thing about when we gave people cell phones. It was because of an equity issue. And then we let people keep their cell phones.
Yeah,
Right.
exactly.
Right.
Yeah.
You know, IRBs like balk at this because for EMA studies in particular, like you might pay people between 75 cents and $5 an entry. And so then like very quickly you get to sort of like these contingency management payments where they're just like, you're giving drug users all this money. And in my case, I only pay cash, which is then like, even more risky in terms of the way that IRBs perceive it.
There are data that you can show the IRB that people use money
For other stuff.
for food and toiletries and it doesn't change their risk of overdose.
I think that's the most important part, because we can also find data that says like they use it for drugs, but in using it for drugs, they're not using it for other stuff that might put them at risk for, other sort of public safety kind of crimes.
Right.
But you're really bringing up a much higher level question, it seems to me, which is sort of how does one balance the potential loss of privacy and survival?
Correct.
And that some folks aren't sure where to fall on that. Like, do I let you track me because it could save my life, but is saving my life actually creating other risks that I may not want to be a part of? So, and I think, we all sort of, we're all tracked all the time now, and some of it is just how much we know how much we're tracked, and how much it's gonna bother us. So I think your question about who is this really going to apply to now is a really big question. And how can we create life-saving devices that don't feel threatening in other ways?
Mhm.
And sort of use these
I'm fascinated by this device. Is there any way that it could be engineered to turn the GPS on only when
Did?
it's activated?
I mean, I think that's a great idea, and the answer is probably. I am definitely not the engineer, but we're in that space. Like we we changed the sensor that we're using so that the algorithm is better for detecting, like working on people with more melanin of different body sizes, because like these SpO2 monitors they're not great for everybody. So like that's a byproduct of having an engineer of color on the grant, which was incredibly useful. And he's now the like co-CEO of the company that's working to develop. Actually, both CEOs are people of color, which is amazing. So I think, but that brings a different nuance, right? Like when we talk about the importance of like diversity and inclusion and anti-racism practices, like who would have thought about? I mean, I hadn't considered that like writ large these very global sensor companies are super like they haven't attended to that. It's pretty racist, right? Like they should do better.
I think this is such a great example of interdisciplinary research where one of the disciplines is drug users, which I think is absolutely fabulous. But it occurs to me like the variables you've presented for these devices are tracking, monitoring, your SpO2, naloxone injection, contacting friends, contacting police. Do you have a sense of what, and I know you've done these in different studies at different times, but within the let's say the drug injector population, not the post-op population, which of those features people like and dislike and you know, because they're, one of your disciplines can tell you exactly that.
Yeah, people don't like the idea of a naloxone injector.
Okay, cause I was gonna, that was.
They don't like it. Like, first it has to make the device bulkier, but also, like, God forbid there's all these false positives, right? And that is the biggest concern that people have, is that you might be implementing an intervention that actually isn't warranted. And it's a very valid concern. And so in these, like, in this like third gen device testing, like, we'll finally be in a position where we're not talking about something that's like hypothetical. We'll be able to simulate like an actual overdose, show them exactly how it would work in terms of, and it's actually called a Wizard of Oz experiment. I had never heard of this, but there's like a wizard behind a closed door who can like do these different alerts to then like have people react to them, which I think is super duper cool. We'll also have people being able to like wander around the community and press an alert and see how long it takes for people to show up. So yeah, I think that that's a really valid point, and that and like the FDA amount hoops and the amount of the amount of capital, venture capital that you need to develop a device that combines like device and drug, like that's part of the reason where we're now, you know, pivoting to something that's more sense and alert. It's also more acceptable, to your point.
So that, I mean, that's really interesting, because of course I hear it and I think, wow, the naloxone injection is the best part, which of course then automatically is the worst part.
Yeah.
So because people don't want that, but they presumably do wanna know, they want a way that their overdose can be broadcast in some way to someone. So who do they want to give them the naloxone?
They prefer their peers. And then EMS. It diverges. And let me take back what I said about, there are some people who are open to naloxone because they're like, I don't want to die. I mean, like, that is broadly the way that everybody feels. And so it's, I don't want to die. And if you can perfect this device enough, I'd be interested in naloxone. But two things. One, peers in EMS, they don't, like, in no way does anybody want to interact with the police, which we cannot control. And also people really want access to a device that's customizable so that they can turn on and off these different response features.
So you could have like a social network group that contacts each other.
Yeah, so like that, if and when we can get this device together, the next sort of behavioral study that like I could lead, because I don't lead these like engineering studies, would be looking at what happens, for example, if we pair up the device with like the Unity Philly Uber for Overdose app, right? And that specifically, it's not a peer network, but it is a lay community responder network. And to be involved, people have to have said like, I am willing to carry naloxone and administer it. And you know, not everybody is gonna be willing to show up on scene, but then they can just be continued to be replaced, because even if they're an alerter and not a responder, they're serving like a very important purpose.
How much time is it between an overdose and not dying?
I mean, there's medical doctors in the room who are better prepared to answer that question, but it varies, right? It varies on the drug, it varies on tolerance, but like, you know, it used to be the case that like people took a long time, and now what we're seeing is like people are instantly falling out. And then the concern is that drugs are always adulterated, and so you might be administering like too much naloxone because somebody is unresponsive because of another drug.
So the other issue.
Please, Tom.
Well, I was just gonna say, to your point, and the concern about false positives, I'm just like interested, like what is the SpO2 trigger that says, like, even if you were gonna have an auto injector that was like, oh yes, let's inject naloxone now?
So that's a great question, and what we have been trying to say, because there are plenty of people who are trying to do this on respiratory rate alone, the one device that's on the market actually requires a base station, like, that doesn't work for everybody, right? We're trying to use multiple biomarkers, and the question around could GPS turn on, we're starting to collect data when somebody has low SpO2 and no movement, right? So that you can triangulate these things to try and really perfect your algorithm. It's a great point, right? Respiratory rate alone is not enough.
So as with some of the other things that we do, and I guess what they used to say about PrEP, or maybe they still do, but does having this device, if it worked and they wanted it, does it increase?
Compensation?
Yes.
Yeah, I totally, that's where you're going. I don't know, our adolescents, I don't, listen, I mean, risk compensation, I think, happens more for like sex, right? Like, sex is pleasurable, there's, if you're on PrEP, for example, you're not gonna get HIV. I think there are definitely, there are groups in which like STI are not stigmatized, like, I think that is more salient in other aspects, and I kind of have this idea of like, well, who cares? If people can get treated, if they're okay with it, like, and that's like a personal opinion, right? Like, I think public health, some people in public health don't agree, and I've been at like the American STD Association annual meeting where they had like a very heated debate on the issue of risk compensation as it related to PrEP. My take and the literature's take as it relates to overdose is the answer is no. Because it's like, first, it's life and death, and secondly, being resuscitated fully sucks. Like, it is painful, and it can put you at greater risk for overdose from subsequent use. So like, it just doesn't, not only does it not stand to reason, but the literature says that people are not using in greater volume. So thank you. Yeah, people always ask that. People ask that. People ask, like, do people really want to live? I mean, there's just like so much stigma that relates to this particular group, like this idea of the moral model and how people are just making these really poor choices without thinking about the fact that like most people can't control their drug supply. Like, it is not an individual choice at this point, unless you've got like, if you have access to like the greatest quality drugs or a safer supply, you might be able to make a different set of choices. But like with the people that I work with, zero control. Couldn't find a bag of heroin if they wanted to.
You raise an interesting, you mentioned like the moral choice kind of issue that we heard about, from Laura, who was a philosopher. And I think what you reminded me of, I mean, a lot of us was, I think, beyond that, because we don't think about it in terms of moral terms, but I think it was really right. And I think you asked the question, what's the bravery? You asked the question, what does that mean? Choice without shame or whatever it was. But I think what you're reminding us is that people themselves may think, drug users themselves may think it's, a moral deficiency, and the people around them. So when you're trying to work with people who are coming in, they may believe this is a moral choice, and so these people are not good. So no matter what we think, it really may matter what the context thinks, and who's going to help, and why people would approve or fund the kinds of things that you're working on. So
Yeah.
we have a larger, more skeptical environment than we may be ourselves.
Yeah, having an ER doc in the room as a part of funding decisions is never a good thing. Because they're just like, they see all these frequent flyers, and I understand like the impact of that and how frustrating it could be to try and like get people into treatment or doing all of these things. But like, they perpetuate so many, in my experience, in the rooms that I've been in, we've been asking for money, like the perpetuation of like really incredibly harmful stereotypes. It is very common. And I think Bennett is in a great place to talk about like risk compensation as your work in the overdose prevention sites in New York. Like, do you see people coming in and using lots more than they were than they would have on the street or wherever they would have been using previously?
No, like we have to, for that study, like evaluating the cities, the New York City Overdose Prevention Centers. Are you on their R1 SMB? But so for this study, like people come to the sites, they bring their drugs, and then they use them there. So we're following them for 18 months in a cohort, how their behavior changes, a lot of that stuff. But that risk compensation is like when we communicate, it comes up less with the participants, less with the providers, but really like when we communicate the study in any kind of setting, like being able to try and sort of make that argument that, this use is going to be happening no matter what.
Yeah.
Would you rather this person uses the subway, in a Dunkin' Donuts bathroom, like on a park bench, and then actually they can come here and they get connected to services, and sort of really making the compelling case that like when you're in the space, which I think is really true, like the least interesting thing that's happening in the service center on point is like the drug use itself is really like a sort of this magical sort of social reintegration experience, and really seeing people who are like at the most farthest fringe of it's like being brought in and just treated with the respect that they'll never get in an ED.
Mhm.
You know, so like that kind of.
What are the outcome measures? What are the outcome measures?
Looking at like non-fatal overdose and fatal overdose are primary, and then also like skin and soft tissue infection as another major one. HIV, I think, would have been more interesting.
And it's a statistical control, not, I mean, you don't have a control group.
No, we do. We have changes that don't offer this add-on service.
Oh, got
So
it.
it's like a kind of more nuanced.
Right. Yeah, interesting, great.
Is anybody using mHealth related tools in their research?
And Kelly, you're gonna be using geospatial, right? So what are the things you're thinking about?
So it's not MRP, it's for the parent grant, and it's, I think it's similar to the project that was described. So the K99 is 2 phases, the first of which I'm validating a self-collection kit, STI testing and trans women, and then the second phase is mapping out their social and spatial network. I'm going to use GEMA, Geographic Unitary Assessment. I am worried about the fact that I'm doing the geographic assessment and collecting GPS coordinates, but I'm also doing the social network assessment and assessing sexual risk behavior because it's an STI and HIV testing grant. So I'm collecting like their sexual partners, their casual partners, and indication of sexual risky behavior
So
in Florida.
yeah, that's tough.
Wait a minute, we're transgender.
But so I would love to know a little bit about like the goal of that. Like why do we need not only the social network stuff, but more importantly the GPS stuff as it relates to STI transmission? Are you trying to identify venues or parties or like what's the goal?
So the goal of it was for the eventual grant I'm going to write is to develop a distribution network for the STI kit that I'm testing. It came out of discussions I had with at least the trans women in Orlando that they identified them.
Yeah.
And they leave essentially STI tests, like STI items, like condoms, tests for HIV, specifically not for bacterial STIs, on like their porch in front of their house. So it's identifying the nodes for that to distribute the kits as well. And I'm also looking at identifying locations for vending machines for the STI kits.
That's very cool. I'd love to talk. I mean, I started like working out of a categorical STD clinic, so I would love to do more about this because I think that there's a lot of nuance there. And I think you're absolutely right to think about like malfeasance, right? And the fact that we should be doing no harm to people and then weighing very carefully like the methods that we're selecting and can this work be done in a different way? Should it be done in a different way to try and, do no harm to participants?
That's my MRP.
Oh, good. Great. I can't wait to hear what you say because it's true, right? Like if they already know who the mothers are and it's already working for HIV testing kits, like one could assume that it might also work for STI self-collection, which is like very acceptable across literature. I haven't looked at it for trans women in particular, but for cis women,
It's not.
really?
For cis women it is, yeah.
I would
So
love.
that's the phase 1 of the study. The mixed method study, the eventual aim is to adapt the kit from its current version based on the feedback we get.
That's so cool because it's also like they're also acceptable to MSM. So it's, I can't wait to hear about the cultural implications of that. Like it's not. I think it's very cool. Yeah. Anybody else? I'll put John on the spot because we've talked about like in like your work using sort of cell phones and other types of like remote non-lab based research. Like you were talking about like consent stuff, drawing back to your MRP with adolescents. You want to talk a little bit about that?
I like the suicide, maybe you could talk a little bit about suicide, also the suicide protocol.
Oh, yeah.
Because how many people are gonna do online research?
My presentation from last year.
Online, you're doing online, yeah.
I think this stuff really applies to all of
Yeah,
us.
John has really done amazing jobs in terms of, ethical issues tied to online research with vulnerable populations. You can't remember.
I'm pulling up my
because
slides
you're
from
very
last
old.
year, cause
But-
we did a session on this last year.
I'm just standing up here, no slides.
I just wanna get like the data correct.
Yeah.
Right.
And I think to your point with like the EMA stuff, like one of the things that we included was like if someone reported a sexual assault, which did not occur in that EMA study with women who are engaging in sex work, like that was the only thing that triggered an immediate response. Right? Like we immediately followed up with like, do you want to talk to rape counseling? What can we do? Was this like inadvertent data entry, which raises questions of reliability? And so then again, like go ahead.
So I was in an EMA workshop last week, and with that, I went through the study, and I can tell like just is it possible that they're just like rolling their eyes? Because I got notification every day, 4 times a day,
Yeah.
to fill out this stuff. Is there possible that they're just filling in answers just to get rid of it and to reach that compensation amount?
I mean, I think it's possible. I also think people just mess up data entry. Like if you can you imagine doing it on your phone or on your watch? You'd be like your thumbs. Like there's no good way. So I think there are reliability issues. And then I do think about any survey that you do. Like imagine you can like think about like what that skip logic is going to be. It is easy to hit like no, I have not.
Remember, like how like if I answer this, I know I'm going to get these answers.
Yeah, so you skip it. So then you need to think about as a researcher, like, do I need to have like a different path? Which is why we had that like daily activities path. Did you find your stuff, John?
Yes, but what did you want me to?
To talk about the concerns you had around like obtaining consent, for example.
So we talked about that actually a little bit yesterday, that in our online studies, we do a video that explains the informed consent process, and then we do a quiz of like the things that we expect people to misunderstand the most about the consent, so that we have an opportunity to remind them of what those essential elements of the informed consent are. So like one example of the quiz item is we ask people like, true or false, you will receive HIV testing and a full panel of STI results as part of the study, which is false because we're only doing HIV testing in the study, and we don't want people to think that like their HIV negative test result means negative for all STIs. And then for minors, there's also an additional component of assessing their privacy concerns. So we ask them how likely it is that their parents or someone else in their house will read their text messages or emails or open a package that was addressed to them, because we're sending the HIV testing kits to their preferred address. And then we ask them how worried they would be if they intercepted a message from us or a package from us. And then if they say there's any combination of both likelihood and worry, then we have, we used to have like a phone call with them. Nobody picks up the phone, so we had to change that to a free response survey that we could then review and figure out if we needed to follow up with them live, which we then got IRB approval to do both by phone or by text message, because this is 16 and 17-year-olds who do not answer the phone. So like we had almost no 16 and 17-year-olds in our first cohort because a lot of them were flagged for privacy concerns and none of them picked up the phone. So we adapted in the cohort that we just finished enrolling to have that free response survey that asked them for more context around like what they think would happen, what the consequences would be, like do your parents know about your sexual or gender identity, and then based on those free responses, a staff member goes through and kind of decides if the person is cleared to move forward, or if we need to follow up with them, which, like I said, we can do via text message. The problem with that, obviously, is that text messages are one of the things that they are expressing potential privacy concerns about. So that becomes a little bit of a challenge in enrolling the minors. But the real big issue, the youth are much better at protecting their digital content than they are about, they're more worried about packages, right? So like they're more worried about the HIV testing kit. So part of that conversation that we have with them is there a safer place that we could send your kit that you'd still be able to receive it, where you know your parents or your siblings or whomever you're living with don't have access to that device.
Yeah, is there a reason why, I mean, I understand the reason why, but shouldn't that also apply to people who are not under 18, concerned about confidentiality at home, depending on the living situation?
So, I, actually in the new cohort, we did ask everybody about their privacy concerns, but I guess like this sort of like extra paternalistic like step of us blocking them. So in the study, you would otherwise, you screen, and then you can immediately enroll if you screen eligible. So we have this step to like block the minors from immediately enrolling if there are potential privacy concerns, just to make sure that they understood they will be receiving a package from us, to make sure that the address that they give us is one where they feel safe receiving that package. So we don't do that part for adults, but we do have the data now on whether like folks with roommates or who live with their partners may not know that they're potentially at risk for HIV, doing things that the partner may not know about, like so they get an HIV test at home and the partner's like, what the hell is this? Are you testing for HIV? I thought, like we only do that together once a year or something. So we do ask it now, but and for the youth, we don't ever tell them like you're safe to participate in the study, and we also don't say like you're not allowed to participate in the study. Once we have contacted them and had the opportunity to like make sure that they comprehended everything about the study, it's up to them whether they want to join or not. So we do clear them to join the study as long as we've spoken with them and feel like they have made an informed decision about the safety of joining the study. So we don't ever block them at that point, but we do stop them from immediately enrolling until we can ensure the comprehension piece, because otherwise like they may never talk to a staff member the entire time they're in the study. So it's like our one opportunity to make sure that they've been clear on like what's involved and the potential risks.
Another thing that came up for me doing studies with transgender youth, and at that time, I mean, the way we were screening them, because teenagers, they're not as we have things now that block things that are coming in, but they would all sit in a room and share the same phone number and everybody be on the same, line. And so we would be checking phone numbers and text, and they would have to text us and we'd have to, anyhow, what I'm trying to get at is one youth started texting us that he was in trouble. And, he lived somewhere in the Midwest and so, and ours was not a treatment study. It was just a survey. So, what we immediately did was begin to not only national phones that you could call for help, but I actually called around and found places in his town that could help him and get back to him. So that was something I was totally unprepared for, in just like a regular survey, but that somebody was able to contact it, and also because you always give your information in the informed consent. So anyhow, that was something now that we think about in terms of referral services, but when you're doing surveys, you don't know where they live and what the resources are available to them. Unfortunately, there are hotlines, but you don't even know how good they are. And then in another situation, I also called the hotline, or what I found was like a resource somewhere to be able to have that person actually call somebody. But anyhow, so those are things that come up that you're really unprepared for, even in survey research.
Yeah, and we do assess suicidality as
Yeah.
well. Most of the validated measures of depression have some item
Right.
about thoughts of suicide
Yeah.
in them. So we also have a process of following up on the degree to which there's an imminent harm
Right.
potentially to them. We don't want to have that information and not do anything.
Oh,
So like
definitely.
everybody gets national hotlines and referrals
Yeah,
at the
we
end
do
of the
that at
survey.
end. Yeah.
But we have a trigger programmed in the survey that like if they express imminent danger,
Even if
clinical
the study's
psychologist
not
will
about that.
follow up with them in
Even if the
48
study's
hours.
not about that.
Correct. I mean, the
Yeah.
study's about prevention, but we also have a nationwide sample of sexual and gender minorities of color. So like we have to have mental health information.
Right.
So we
So if
have
you collect it,
suicidality
okay.
data. And so if
Right.
anyone, regardless of age, if they report active thoughts of suicide in the past 7 days, then they get a call from a clinical psychologist within 48 hours.
Right, yeah,
thing that's been good with the 988 rollout is that it's textable. So for people who don't wanna talk on the phone, it does open another access option. I think I've had to remind patients of that even in the emergency room too, that you can text 988 and human will text back. So it's another point of access. And it's multilingual too. They'll text back.
No.
So yeah, cause like you can't text 911 or other non-10-digit numbers, but you can text that one. I have not texted it, but the people that I know have say they get, it's not a chat bot, it's like a person.
that's amazing. Wow.
It's not Brenda's algorithm.
What?
It's not Brenda's algorithm
No, it's not
responding.
Brenda's algorithm that talks to them? Oh my God, yes, I'm going in another direction, but yeah, I listen to audiobooks and you can get audiobooks to which an AI is reading it. It's so creepy. I mean, they did not sound human. I don't care how much they were, they.
Sure it's an AI?
That's what they said it was an AI, yes, I don't know, who knows? But anyhow, I'm off track, sorry.
No, that's okay. I mean, I don't have a ton more to say, but I do think that, like John's earlier comment about delivering STI kits to people's homes and the risk that that might put them in, Celia's experience of this kid calling her, I think, and in my particular case, and you know, in the EMA study with women engaging in sex work, like we were doing weekly interviews with them to be able to follow up on those geo coordinates that they were providing us. And it was often, I mean, I was so young. Everybody had my personal cell phone number, like every sex worker in Indianapolis had my personal cell phone number. And I was going to people's houses, which I actually think gave me way better data, because you show up at somebody's house, like what are you signaling to them as like your value in them as a human, your perceived safety about being in their space. Like I think it's incredibly valuable. That said, like in terms of, you know, John's and Celia in my case, like it also can create a lot of moral distress for the researcher, like questions around like you're respecting somebody's agency and autonomy to choose, that is our obligation. And what if you go to their house and they've decided to have whoever is at home, their kids, their partner, they may or may not know that they're engaging in sex work, and then you show up. Like, what's your cover there? And so that to me was like very, very stressful. I also there was also a circumstance in which I was like truly felt like I was in danger, and then changed my protocol. But like that wasn't, my danger was stressful, but it was not morally distressing. I was just like, okay, this is bad, and so then you change. But like I couldn't change, we can never change what people choose to engage in and how that may bring up issues of like confidentiality and privacy for us. And I think that those are even more salient in longitudinal studies, where, especially interview studies, where we're really developing these like very supportive relationships with people, and the importance of like ongoing consent and reminding people about what may trigger you to break their confidentiality. So in my case, I was with somebody, they were intoxicated, and she made like an offhanded comment about, you know, physically harming her partner. I did not think that she meant it. And I didn't, again, very young, like didn't say anything, didn't know what to do, left, called my PI, and I was like, holy shit, I think I just messed up. Like this was very, you know, like I think she was joking, and like what was my obligation? And she's like, your obligation was to remind them that if they disclose they're gonna physically harm somebody or themselves, that you have to do something with that information. So if you see that coming, stop the train so that they can make a choice about what they actually wanna disclose to you or not. And again, I think this woman was joking, right? But like that was not my decision to make. It was her decision to make around like what she felt comfortable disclosing. And I think the same thing again points this idea of like continued and ongoing consent, like speaks to something that Faith brought up yesterday around people being involved in a study, consenting to biobanking and not really recognizing that that was something that they had agreed to. And so we talked about, you know, separating out consent. So it's like, here is this part, and can we do this other part on another day? Was that you or you both? You had a study that made you stressful, and this is something that you're doing in your MRP, right?
Yeah, I think you were talking about someone you brought up like doing, yeah, the separate consent so that it's clear
Mhm.
what people are consenting to.
So again, like respecting people's agency, but also like truly trying to think of how we're setting up our consent processes so that people are making informed and ongoing choices. Especially like people are, at least in my experience, like incredibly altruistic. People engage in research for which they will receive no benefit because they want to help other people. And I think this is particularly true like with people who are using drugs, like it might like sex workers, things like that, where they're just like, this has not been great for me, and I will do anything in my power to try and help people who are either going down this path or preventing them from going down this path. And so like really stressing, you know, being conscious of that, so that like again, we're continually giving opportunities for people to not do something that makes them uncomfortable and allowing them space to talk about it if it does. That's all I got.